The content provided in this podcast is for informational and educational purposes only and is not intended as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
Is it my story, your story, his story, her story, Jane's story, Joe's story? Is it just an allegory? The show's about to start and we still don't have a name for it. Bop, 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 bop. It's a long story.
Aging and cystic fibrosis are words you don't always hear in the same sentence, but on this podcast, you'll hear them all the time, with relevant discussions and unexpected explorations wherever this podcast might take us.
So many people with CF are living longer thanks to modulators and medical advances. We thought it was time to get into some real conversations with expert guests and people from all walks of CF about what living longer with CF means, the good and the not so good.
I'm Dr. Ahmet Uluer.
And I'm Lauren Harvey.
I'm a medicine and pediatric trained pulmonologist and director of an adult CF center at a Harvard-affiliated hospital right here in Boston.
And I've had CF all my life and was recently diagnosed with CF-related diabetes. I am committed to creating a supportive space for those with CF and their loved ones.
I will bring the medical expertise and provider perspective.
I bring the real-life CF experience.
And together we bring you It's a Lung Story, a monthly podcast about aging with cystic fibrosis, where we take a little time to tell a lung story.
It's a long story.
It's a lung story.
Woo-hoo!
All right, that
Amazing.
felt good. And maybe the best singing of our lung story jingle yet, I think. No,
Ooh,
probably not.
Wow.
I just threw it down there.
I think we've been doing this long enough. We're going to have to start harmonizing ourselves.
I think actually that is really a great idea. Definitely
Yeah.
next time we're doing it.
Yeah.
Hi, everybody.
Well, it's actually Lauren's
and,
turn next time. So,
all right.
yeah.
I'm planning something special for next time. Don't you worry.
Okay. Shoot, she's going to best me. All right. Hi, everybody, and welcome to the CF and liver disease episode. I'm Ahmet Uluer, and I'm just so happy to be back after taking a month off from the podcast and to be here with my two friends. And as always, I'm joined by Lauren Harvey, who dreams of becoming a master sommelier with in-laws helping her build up her massive wine cellar with a Wine of the Month Club membership. Lauren.
Hello. I'm having so much fun with my wine. I promise I'm not drunk for this recording, so we're going to have some fun.
And a warm hello to Andrea, who just came home from the Cape, also known as the New England Riviera. I think I may have just named that. And about to celebrate her 27-year lung transplant anniversary. Hi, Andrea.
Hello, that's right. Yes, celebrated on Sunday, but it's really just a all-month fiesta.
That's right.
Yes.
So it was in September, but you're celebrating in October?
Well, it was Sunday, and I guess I'm celebrating it
Okay.
as long
So
as people still send me gifts and flowers and
Well,
arrangements.
It
that
is.
kind of
It is. It's actually everyday celebration, the whole
Right.
year long, and then another
No.
year, and then another year.
It's generally been more of a reflectful day for me. I sometimes go out by myself and go to like a body of water, or I've been many places over the 27 years and find a place to just be quiet and sit with it. But we did have like a really big blowout when it was my 20th, like a party. But generally speaking, it's not like a big to-do.
Well, where were you? Where were you on Sunday?
I was at a body of water thinking about the people who got me here and the people who I wish were here with me and who on the hardest days, you push forward for them.
Thank you for sharing, Andrea. I know this is a day of mixed feelings, but just we're so glad you're here. But before we jump in, we wanted to set the stage for today's conversation. We're trying something new with this episode, and perhaps going forward. Today, we're going to have two experts on the show. One went to medical school, and the other one has lived through CF liver disease. And I actually heard a term yesterday from a very bright friend of mine at the CF Foundation, Quinn. And she referred to this type of collaboration or collaborative dynamic as complementary expertise. And that is exactly the best way to describe our two guests talking with each other today to teach us about CF-related liver disease. So I would first like to introduce Sarah, or when her mother gets mad at her, Sarah Joy Richards. Sarah is 35 and not only underwent a double lung transplant at Duke University in 2019, she also received a donated liver on the same day. She has a CF team in Atlanta where she lives for her CF care, and then is also still following up with her Duke teams for both liver and lung transplant care. Sarah will give a lot of perspective on living while experiencing liver failure and the challenge of having to be told you need to have a lung and liver transplant at the same time in order to live. Sarah, welcome.
Hi, thanks for having me.
Also joining us is Dr. Alvin Jay Freeman, or Jay. He is the medical director of the pancreatic care for the Pancreas and Liver Care Center at Nationwide Children's Hospital and professor at the Ohio State University College of Medicine. He's a hepatologist and liver transplant doctor at Ohio State. He treats the hardest liver cases, guides patients through transplant and recovery, and has authored numerous manuscripts and participated in international position papers and guidelines, making him the ideal person for us to talk with about liver failure and liver transplant. Welcome, Jay.
Thank you so much for having me. Pleasure to be here.
So we're going to get started right away, and not necessarily in a linear conversation. We may bounce around a bit. Sarah, we're going to start with you, and we wanted to talk about liver disease, and more specifically, end-stage liver disease and failure in CF, since it isn't something discussed very often, and we don't have a large number of providers who are experts in advanced CF liver disease. I've had the opportunity to take care of several people with CF-related end-stage liver disease, and I have seen them suffer, which underscores, the importance of learning more about this serious complication. So can you briefly introduce us to your journey with CF-related liver disease?
Sure. So for me, growing up, I didn't have a lot of lung and liver involvement. But around the age of 13, I started to, liver disease for me was sort of something on paper. At clinic, they started to talk about elevated liver enzymes. And I would notice when I was maybe going on an antibiotic for my sinuses, I would get really fatigued, more so than just how you kind of feel yucky whenever you are on antibiotics. So for me, for a long time, that was how CF liver disease was for me. It was more on paper than, in practice. But when I was 16, I got really sick. My liver kind of took a turn. They started to talk about transplant. They wanted to start the evaluation process. But suddenly, within like a month, my liver just, boom, it just went back to not being great, but not being bad enough to be talking about transplant. And just sort of like scooted along for a while. And then in 2015, 2016, I started to notice that I had what looked like this 9-month pregnancy belly on me all the time. My calves were really swollen. My feet were really swollen. I was having to wear flip-flops year-round by the time we got to like 2017. I had to come out of grad school, and really, it just became this everyday slog. I was bedridden a lot of the times. I was taking a lot of medications like Lasix to try and get some of this water off. Obviously, being that swollen led to a lot of lower back pain, stomach pain. Fatigue was really bad. I could be sitting down at the dinner table talking, and I would just fall asleep. Just mid-conversation, I would fall asleep, be asleep for like 2 or 3 minutes, and wake up and not know that any time had passed. I wasn't working. I wasn't going to school anymore. It was really just trying to survive all of these symptoms. And we started to do these stomach taps where they go in and they kind of take some of that fluid off. But when they do that, that causes a pretty big fluid shift with your electrolytes. So full body cramping, people were having to lay down on my body to keep like my arms from coming up and cramping, or my legs. Even just walking maybe 10 or 12 feet, my legs may cramp up to the point that I needed to use a wheelchair sometimes. And then all the time, sleeping all the time, but never feeling rested. And by the time we made it to 2019, my CF doctor, Dr. Hunt in Atlanta, he was like, look, your lungs aren't great. Your liver is really bad, but we're nervous that to put you through your liver transplant that you need, your lungs will not be well enough to survive that surgery. He was like, we really want you to have these done at the same time. That was a lot to take in. And where I was located, they were like, Duke up in North Carolina, they have the system down, what the liver needs, what the lung needs. They're often at odds with each other. And he was like, if you go there, they're going to be able to take care of you. And so I went up for an evaluation late summer, I believe late July. And Duke was like, yeah, you're in your window. And so I had moved up to an apartment there with my mom 1 month later, August 31st. We were moved into our apartment and getting ready to start our transplant journey. And they were like, you may be here for a year or two. But I really took a turn, and I ended up being hospitalized September 10th. And I stayed in the hospital until my transplant on October 7th.
So you're not only facing this really difficult decision and conversation, you're moving to a whole new city and learning a whole new medical system, a new team, quite extraordinary.
Yeah, that was a lot to take in, especially with CF, you're in the hospital a lot. You know your doctors really well, your nurses, your floor on the hospital, everybody knows each other. So to move to a whole different system, to have to learn people, for them to have to learn me, that was really difficult. It definitely made things more difficult to not just have that familiarity and kind of family effect of your home hospital, if you will.
I can't even imagine. That's a lot.
Yeah, when I think back, everything happened very fast for me. In January of 2019 was when the idea was kind of floated to me that I would need both. I'd always kind of known that a liver transplant was somewhere in the distance. Lungs, I just had not really considered. I think I felt that, I would need to be on oxygen. I would need to be completely bedridden. There were just certain checks that I thought had to happen before we arrived at lung transplant. So that happened. Evaluation happened in the summer, which whenever I called to schedule that, they were like, oh, you can come anytime from 2 weeks from now to the end of the year. And I have anxiety, so I was like, I want to get this over with. And I'm really glad that I did, because later they were like, once they saw how bad everything was, they were like, you would not have made it to Halloween. So that's another thing. Trust your gut. If you're anxious, that's okay. Sometimes it comes in handy, but everything happened really fast. Even when I was in the hospital for about a month, I was listed on October 1st. The transplant happened October 7th. And a lot of that month was convincing the liver team that I was not past my window, that I could survive the surgery. Lung team was very confident, but liver team was hesitant. And they had good reason to be, because I was really malnourished. My true weight was somewhere around 80, 83 pounds. The rest of it was fluid. I was clocking in at 116 to 123. And, being malnourished post-transplant did make my recovery a lot harder. I was in the hospital for about 100 days post-transplant.
That's a long time. And while you're talking about all the malnutrition and everything like that, I'd love to bring Jay in and ask, what exactly is CF-related liver disease? Because for me, it's never really brought up in any of my clinic visits. I never really knew that it was a possibility until recently. And so I'd love to hear what it is. And is it genetic, environmental, or just by chance? I have no idea.
Yeah, Lauren, it's $1 million question in some ways. What is CF liver disease? I think Sarah kind of hit the nail on the head on the experience of patients that have liver involvement. It's something usually on paper, right? To have a patient come in and say, oh, your liver enzymes are a little elevated, that's basically just going to be a given at some point in your life when you have cystic fibrosis. But it's really only a small percentage of patients, maybe 5 to 7%, that have advanced CF liver involvement like Sarah had, which is where we talk about portal hypertension, which is when the blood isn't able to get through the liver and back up to the heart, or having synthetic dysfunction, which is when the liver's not doing the jobs that it should be, causing you to have ascites, where you have that belly that looks like, you're 9 months pregnant, as you described it, those fluid shifts, and what you described as altered mental status or encephalopathy, where you're able to kind of fall asleep. And so as a provider, it becomes very challenging in that, where on this spectrum of CF liver disease are you? And like I said, the mass majority of patients are going to be on that lesser end, benign increase in liver numbers. It's just something that is a lab value that doesn't have a big clinical impact. But knowing that there are a small subset of patients that are going to go on, and how to monitor those patients is incredibly important for anybody with cystic fibrosis. I have had a handful of patients that have had normal liver enzymes, not had any symptoms, had a little bit of belly pain, and showed up, got an ultrasound, and had end-stage liver disease. It can be that much of a silent disease that you don't expect, because you're used to getting your FEV1, you're used to getting your sputum samples, all those things, with CF-related diabetes, checking your glucoses. You have all these things that we're looking for, and with CF liver involvement, it's just not that noticeable sometimes, and that can make it very challenging. Now, as to what causes it, it's a great question. I would love to have that New England Journal paper when somebody figures that out. But there are some different theories as to why. So to begin, the CFTR protein is not on your liver cells. It's actually on your cholangiocytes. So think of your gallbladder and all the tubing that gets that bile into your intestine. And so that kind of starts with the theory that maybe just like you have viscous secretions within your pancreas and your lungs, do you have this viscous fluid going through your liver that causes your bile ducts to get clogged up, that then leads to inflammation in the liver? That was the prevailing thought years ago. But really, when you look at histology or pieces of the liver, it doesn't really fit. You don't see these big bile plugs or things like that, but you do see a lot of inflammation around these bile ducts. So a lot of the prevailing thoughts has to do with actually microvascular disease. So small blood vessels within the liver that get inflamed and cause problems, or even as Sarah has alluded to, you get these recurrent infections, you get these alterations in bile acid transportation and composition that then impacts the liver. So a lot of work is still being done in this area to give you that why answer, what causes this. I don't think, at least for right now, it's what you eat. I don't think it's environmental, although with the success of modulator therapies, obesity is on the rise, fatty liver disease is on the rise, so maybe there will be a component of that moving forward. But I think more likely than not, and this is something Sarah probably hates to hear, it's bad luck. Just why you were the small portion of the people with already a rare disease that had this complication. Unfortunately, we're unable to tell you right now.
Yeah, and to pivot off of that now, because Sarah mentioned trying to find that right window, and maybe the question I want to ask you is, how do we differentiate? I mean, so how is CF-related liver disease different than other types of liver disease? And I'm going to ask in a context of, there is this model for end-stage liver disease score, the MELD score, and for pediatrics, it's the PELD score. From my experience, people with CF, the way that is scored, don't hit those points to get enough of a score to be eligible for a liver transplant, or score high enough to be getting one, even though, like you said, they may have evidence of end-stage liver disease and they're having all sorts of other complications like encephalopathy, and maybe you'll talk about that. So how is it different? And are there any changes to the way that scoring is done to be eligible for a liver transplant, or to score high enough to get one, that will help the transplant teams score in a way that CF-related liver disease is going to be recognized as advanced by the scoring system?
Yeah, no, it's a great question, and unfortunately, it's another one of those that doesn't have a short answer. So as you alluded to, there is a scoring system. You get points based on your disease, and the higher your points, the more likely you are to get an organ offer. The problem that we see is both the MELD and the PELD, so the adult and the pediatric version of these scores, are really driven by what we call synthetic dysfunction. So that's, again, filtering toxins, making proteins. So the lab values that get you points are something called an INR, which is basically a reflection of how well you're able to make clotting factors. Your albumin, which is the most abundant protein in your blood, and then some other, end organ damage, such as if you start having kidney disease. And generally, patients with cystic fibrosis don't have those complications. It's more about a scarring of the liver and that portal hypertension, especially at first, that predisposes them to ascites, that fluid collection. It predisposes them to having varices. So everybody's heard of varicose veins in your legs. Well, you can get those same type of superficial blood vessels within your GI tract, your esophagus, or your food pipe in particular, and those can bleed. And in adults, that has like a 30% mortality risk. I mean, this is like a serious complication.
I did have that.
I'm sure. And some of the worst varices I've ever seen are in cystic fibrosis patients, absolutely, because they really get this severe portal hypertension. So even though they've got this severe disease, this life-threatening disease, that's not what is scored on that MELD and PELD. And so if you think of, as an example, a 30 is when you start getting serious offers. When you put a CF patient on the list, they might only have a score of 6 or 8, which is going to get you nowhere near getting organ offers. So we end up having to ask for exception points. Now, the donation body that oversees organ donation, they have done a CF exception score, but it's really based on whether your lungs are severe or not. And currently, that actually sits at having an FEV less than 40%. We've been trying to push that up to 60%. Well, that goes back to what Sarah was talking a little bit about. Like, how are you going to survive a major organ operation if your lungs are so bad that your FEV is less than 40%? So unfortunately, even that automatic exception score is below the average. And so it's still not that high. And most of our CF patients don't even hit it because we're trying to do this before their lungs get that severe. So it's a very difficult system to navigate. You do need to have providers that understand where it fails the patient, and then are able to write good exception letters to the governing body to ask for these points so that somebody like Sarah can get the organ that they need.
Sarah, you were going to reflect on that?
Well, kind of touching on like the varices, that was my first ever ICU stay. I'm used to having hemoptysis where you cough up blood. And I was having more of that. And then we realized that there was obviously some kind of internal bleeding whenever I went to the bathroom. And they brought me in, and I was like, okay, this must be a really bad hemoptysis. And they were like, no. And we went in, I believe they did a banding procedure where they kind of went in and banded things off to kind of prevent that. And I actually had Jay, you may be able to speak more to this, but sort of stabilize my liver. Whenever I first got to Duke, they really wanted to do something called like a TIPS procedure. And like I said, the stress of the move really like made my health take a turn. And so they were like, well, that's off the table. And whenever I came into the ER there at Duke, they were like, you're not leaving until you get your transplant. And it was September 10th. And I'm thinking, oh, I'm going to be here for like a year. Because I could not process, no, it's all happening so much faster than even they thought. And yeah, as far as the score, every day you're in the hospital and everyone is like, we're trying to get you listed. And there's so much, they had me taking potassium, they had me taking all of these different electrolytes because they were like, we need to get your numbers right. So that month that I was in the hospital, I think a lot of people think, oh, I was just sitting there, just getting worse and worse. No, they've got you in PT. They want you to get strong so you can learn, there's this razor thin line of being strong enough to survive the transplant, but being sick enough to prove that you need it. And I really realized what a balancing act that was, and the dangers of listing me for lungs even an hour ahead of listing me for liver. They were like, we don't want your perfect lungs to come, but you're not yet listed for your liver because we may miss it. So a lot of complicated stuff around scores and around how you get listed. And that was something going in. I had no idea how complicated that all was. I just thought, well, if you're sick, they number you, like you go next. And no, that was not how it was at all.
And Andrea, this is something that all transplanted people know about, right? That's something
Yes.
a lot about.
I'm actually so old that I went through my first transplant with the deli number system, where you get a number and you get in line, and it doesn't matter. There's no there might have been a little bit of tomfoolery around the top three, but you just got in line, and it's like, okay, you have 2 years, so you get to the headline. But yeah, I think, I'm in a situation myself right now where it's like that razor line we're looking at, where does that fall for me? But I have a question going back to the liver. Being 55 and having seen a lot of CF in my life, I just recently, and maybe just my eyes are wider open because of doing the podcast, but I had a CT scan, and it was for my lungs, but they always read everything. And it was just, going organ by organ, and it's kind of like a horror story if you're not used to it, because you're like, oh God, I've got all this stuff going on. But when it came to the liver, it said mildly nodular liver contour suggests hepatic fibrosis, cirrhosis. And I was just sort of like, when do I need to be concerned about this? Or is there, aside from transplant, which I'm pretty sure I'm not there yet, but my question is, are there other interventions, are there other stopgap areas where we should say, okay, let's take a look and see here, because we're all aging now? I guess what I'm asking is, what do I do with that information?
No, it's question I get asked a lot. So I think I'm going to back into the answer just a little bit, if you don't mind.
Not at
And
all.
by that, I mean, the CF Foundation has gotten a lot more mindful of this condition. The kind of presentation that I spoke about earlier, where you don't know that you have anything, then all of a sudden you get a CT and you've got this nodular liver. And so it's always been part of the screening to get labs once a year, which includes your liver enzymes. If your liver enzymes or your GGT, which is one of those markers of the biliary system, is elevated, that does get most providers' attention now, and we'll get you to a GI or a liver doctor to at least give you, a once-over, if you will. But I think the bigger thing that's happened recently is the recognition that having a high AST, ALT, GGT does not mean that you have liver disease, and having normal values does not mean that you don't have liver disease. And so now, at least within pediatrics, there is a screening ultrasound to be done every 2 years after the age of 3 or at time of diagnosis. Now, those guidelines are going away by the time you're transitioning into adulthood, but I do know a lot of the adult providers that I work with, they still say, let's just get an ultrasound every 2 years. Because what's the harm? It takes 20 minutes to get a limited ultrasound. If you pick up something, then great. Usually we're getting Doppler, where we look at the blood flow through that portal vein as a marker to make sure you don't have some of that portal hypertension, so that we do pick up disease much earlier than what you unfortunately experienced. Once you do start showing signs of more advanced involvement, so high GGTs, irregular contours on your imaging, things of that nature, then we start looking at our labs a little bit different. Instead of blood work every year, we really want to get them every 6 months to every 3 months. Believe it or not, it's usually not the liver enzymes, that AST and ALT that a lot of people talk about. I'm more worried about your CBC, so your white count and your platelets. If I start to see those go down, that's more of a sign to me that you have hardening or scarring of your liver and that you're at risk for getting portal hypertension. And then that's when we start worrying about those varices that Sarah was alluding to earlier. So those are all kind of the run-of-the-mill things. Now, when you start seeing a specialist, then we're going to start talking about things like elastography, which can be done by ultrasound. That's usually either called shear wave or ARFI. But now we can also do this with MRI. And then you might have heard of something called FibroScan or transient elastography, which can be done at the bedside, takes about 2 minutes to do. And so my point in bringing up all these different labs and modalities is there's not one thing that I think you should hang your hat on. There isn't one test that says you have liver involvement or advanced liver involvement in CF. It really is a constellation of all these data points and being able to put them together in their trends in order to know what's going on. Going back to platelets as a prime example, usually in chronic liver disease, we don't really worry about that number until it gets below 75 or 50 as being a risk for having varices. But we also know it's what's called an acute phase reactant. So if you're sick, your platelets are going to go up because you're sick. And so in a CF patient whose platelets have gone from 150 to 120 to 100 or 90 over time, that bothers me more than maybe one of my chronic patients who sits around 50 or 60, because that can actually be a sign that their liver disease is progressing from their trend, and having all those other data points becomes crucial in kind of staging the patient and letting them know how worried we are. Are we getting into that window that Sarah has talked about, and all the other nuances when it comes to care? So it's a very long-winded answer. I'm sorry, but I guess my take home from this is, yes, you have something that's abnormal. It deserves attention, but it probably deserves some of these other things that we're talking about, and then putting those all into context together to know really how to stage your liver involvement.
And I would say the CF Foundation came up with the care team model, and it really just shows you that we need more people like Jay who are liver specialists to be able to, reflect on some of those changes that somebody who's not seeing liver disease all the time may not.
Right.
Because it's complicated.
I agree. We need more Jays in the world.
Yeah.
I'm not sure
Well,
my
I'm
wife
learning-
would
I'm
agree with you,
learning
but
so
okay.
much already tonight, I'm like, I'm listening, but I'm also typing. Yeah.
Yeah. And
that
I
it's
actually have a
back, but-
follow-up question. So you talked about kind of the screening aspects, but for someone like me who doesn't get normal screening for it, are there early signs that I should be watching out for? Sarah, chime in if you have some ideas too. But like for me, I don't ever really get screened for it, but is there anything that I would notice kind of, off the bat if I was to think about it?
Yeah, so your labs are probably going to show it beforehand. Even though you're clearly an adult, I would bring up with my provider the idea of getting a screening ultrasound to see what they have to say. And then I think going back to the way Sarah discussed her presentation is we have to remember that when something doesn't add up, we need to look somewhere else. So she did not have overt signs of liver disease, but we started talking about fatigue, eventually cramping, this fluid accumulation. All of these things are not easily explained. The fluid accumulation, you start thinking about liver pretty soon. But, when things aren't starting to add up, it's time to start asking questions of our other specialists and what we need to be doing. Blood from above or below gets anybody's attention as a sign of portal hypertension. That's not usually something that's ignored. The little bit of fluid. And then, Sarah described a pretty significant altered mental status or encephalopathy where she was falling asleep. But if you notice that, you do kind of just space out, you daze off, you miss a minute here or there, or you're talking to your friends and family and they talk about how, where were you? Why weren't you paying attention when we were talking? Those can be soft signs. I actually like to joke about, it wasn't a CF patient, but I diagnosed one child with encephalopathy based off their inattention to watch Shark Week. Because that was his favorite thing to do with his parents was to watch Shark Week.
That could go
and he's
either
in
way,
the
I'm just
hospital
saying.
and his dad's like, he wouldn't stay up to watch the Makos. And I was like, well, wait a minute. I know this kid, this is not normal for him. And so, just catching those clues that, this isn't me. This isn't what I'm normally like. And I'm not saying that is liver disease, but that can certainly be part of the conversation.
Okay. And Sarah, did you notice anything?
Yeah, so I think things that I would add up, or things that I think could easily be confused. So having that big belly, well, what's the other thing with CF? Digestion, that's CF belly. It's like I've had issues in the past and even since transplant with like partial blockages and things like that. So it's not always clear. It's like, oh, well, I've got belly pain. Oh, and my belly is distended. Okay, well, it could be either. And I think at first I kind of attribute it to that. And then with the swelling in my legs, like my doctors were like, actually, this is liver. And I just thought, wow, like my beads are not working or my enzymes are not working or something like that. Other things that like my doctors kind of warned me about, to be really personal, is like lighter color stools, things like that. Whether that's still a factor, but that was just something they said to look out for. And then antibiotics that I could normally tolerate, I was getting to the point where I just felt so sick and, really drugged towards the end of even doing like a 10-day course of like Levaquin, which I normally can tolerate. And we were having to stop medications early because I felt so terrible. So I guess just kind of, taking account of your symptoms. And if you notice like, well, I've not had a problem with my enzymes, but my belly is always distended. And well, now my calves are kind of big, my feet, things like that. Those are areas that I just felt like I attributed it to one thing, and looking back, it was actually my liver.
That is like so helpful to hear it from, I guess, the source. Although I read about it on social media where you're pretty vocal about it.
Complementary expertise.
I also was wondering if you wanted to share how well you're doing now, which is like what drew me to you online, which is some of your exercise programs. And, it's been a couple years since your double and what you're doing right now with all of that, that gift.
Yeah, and I'm always sort of cautious that, because the thing with transplant is it could always come back where you need a second one again. So I am very grateful for this time that I have right now. It's October 7th will be 6 years for me. And the first few years were definitely not as good. I really feel like this year and last year, I have really kind of come into my own. And I am doing things like I'm a person who goes to the gym and I have a personal trainer. And I'm able to do those things through a really great organization, Breathe Strong CF, who provides exercise grants for those who have cystic fibrosis. I can't say enough good things about them. And I got really great news at my most recent transplant visit, because they were like, your actual lung capacity has gotten bigger. And they told me that would not happen unless you were they're like, medication can't make your lungs actually get bigger, your lung capacity. They're like, that has to be something that you're doing. So I was able to tell them, well, I have a personal trainer now and I'm going to the gym twice a week. And they were like, that's it. So I was really glad to know that it works, but I'm like, oh no, now I got to keep this up. But it's such a different way of life. And I think that when you first hear about transplant, when you are someone who has CF, you were born into this. You don't know another way of life. And, CF is progressive. So when somebody comes along, with transplant and the doctors are telling you like, afterwards, everything's going to be better. You just can't grasp that there's another way of living than how you have. And, by my point, it was, I would wake up, eat breakfast, go back to bed, and wake up for dinner, go back to bed. I really had no quality of life. And once you get on the other side of transplant, there's the immediate first year that is really, really tough, as you know. To me, I felt like it just sort of broke me down as a person. And then I sort of built myself back up, thankful for my family, my friends, my doctors. And now I'm doing things that I never imagined that I could. For me to get up, be up, run errands, for me to be able to do two things in one day, like I can go to Publix and I can also, go out to dinner. That's such a gift. That is not something that I was ever able to do. So this is a wonderful time, and I'm trying to enjoy it without being too worried about what might happen next, and just, appreciate where I've been and really thankful for where I am right now.
We can feel that thankfulness, and it just puts a big smile on all of our faces just hearing you talk about it. I was going to just reflect back to Jay. I mean, what I love about taking care of people with CF and chronic illness is that you really get to know your patients, and because I think in a quick visit where you don't really know somebody and you're just hearing those high points and trying to make a decision what to do, I mean, Jay's relationship with that patient and realizing that there's something wrong there, I mean, is the kind of sort of physician-patient relationship we really want, and I just love that story. Sarah, when we first met, you said something that really kind of stuck with me, and it was that, you felt that when you were talking to the lung transplant team, it may be not the one that you eventually went to, but you talked about them as selling you something that just didn't seem right, or maybe there was, they were promising something. And I just wanted you to reflect on that, and, why'd you feel that way? And now being on the other side of this, how do you reflect on that?
Well, being born into CF is one thing. You have no memory of anything else. I remember there was a gentleman going through transplant at the same time as me. He'd actually been at ground zero on 9/11, and that's why he needed his lung transplant. He has memories of when he could do whatever he wanted. When he was quote unquote healthy, and there were other people there who didn't have CF that needed a transplant. But for me, I don't think I've ever been able to wake up and just do what I wanted without needing to do breathing treatments, without needing to take medications. And while I still have a lot of medications that I have to take now, I'm not doing my breathing treatments. I don't have to this side. And that's, as anybody who knows who does it, that's like 4 or 5 hours back into your day. It's hard to believe, and you don't want to believe that this is out there. Your brain can't comprehend that. Every time that you start an antibiotic and your doctor is like, this is the thing that's going to work, and then it doesn't, and you're like, okay, but to be going, there was one point I was going into the hospital every month and staying for 2 weeks. And that was just, you slowly get to that point in life. I was once a week having these stomach taps, and that just becomes your life. And you forget even just 5 years before that you didn't have to do that, because it just slowly happens. And to wake up on the other side of transplant, and, I remember waking up from my surgery, and even though there was pain, I remember the absence of the liver pain that I felt daily. So even in that moment, I kind of knew, like, oh, something's different. Something's happened. And, it was 100 days in the hospital. That was a really long amount of time. But once I got to the other side, there were so many little things. I can remember taking a really good deep breath for the first time. I remember it was winter whenever I got out of the hospital. North Carolina, there was snow on the ground, and I took a breath, and I could feel that cold in my chest, and it did not set off a 20-minute coughing fit. It's just, there's so many little things that it changes. And you think about, oh, now I can travel, now I can do things like that, but just those little things, too, that it changes is incredible.
Yeah, you were reflecting on that throughout that pathway, or that your life, you were being promised, hey, this is going to feel good. Like, you just were thinking, I'll believe it when I feel it. It's easy for people to say this is going to be the big game changer, but like, now looking back, you're seeing that. I mean, thankfully you took that leap. I was going to say, Jay, kind of going back to the scoring system, and because I was taking care of 2 sisters, and I think they'd be okay with me talking about them. But 2 sisters, and they took 2 different paths. I mean, Lauren's question was, why do people get liver disease? And, these 2 sisters had, that bad luck. They both had advanced liver disease. And one of them got a transplant because of a scoring system that allowed it to happen earlier, and the other didn't. And the person who got the transplant, their lung disease didn't progress, and they're doing well. And the sister didn't make it because that scoring system and their lung disease progressed, and lung and liver, Sarah, isn't done everywhere, as you already know. You went to the best place for it at Duke. When you see somebody who's in front of you, like, how do you work through that problem? Because that there's that sweet spot, that window. I mean, how do you counsel people? How do you work through that in your head and with them, and to make sure that they don't miss their window? Is there anything you can do?
Yeah, it's a lot of thoughtful conversation is the really short answer. And a lot of balancing as everybody's kind of discussed. If you look at the distribution of when liver disease tends to be the worst and when lung disease tends to be the worst in CF, unfortunately, they just don't match up. It's usually in the teen years when you typically see the worst liver involvement and patients need a liver. And then it's usually kind of in that mid to late 20s, sometimes a little bit later, that the lung. So even though that's not a huge time frame, and that 10 years, a lot can happen when you're trying to balance a lot. Currently, especially in the era of modulator therapy, there is the idea that if you can do the liver first, get somebody on modulator therapy, that you might be able to actually improve their lungs with that therapy, that they won't need a lung transplant. The data after liver alone shows that lung volumes, FEV1, improves for about 3 to 5 years. That was before modulator therapy. So now if you can sort of slow that progression, get somebody over from a liver standpoint, there is this idea that maybe you can keep the lungs healthy enough and then let them heal with the new therapies, that you might be able to save them. On the other side, if somebody's going to need a lung transplant and their liver is already starting to show signs, the approach has really been to do both organs at the same time. The data is mostly out of Europe, although there is some US data that shows that patients tend to do a little bit better if they have the liver with the lungs, especially from like a bronchiolitis obliterans and kind of rejection standpoint from the lungs. The idea is that the liver is kind of the inflammatory immunological gatekeeper of the body. And so if you bring the liver along with the lungs, you're less likely to get those antibodies against the lungs, have less rejection, things of that nature. But there are certainly times where the liver's perfectly fine and somebody needs lungs, and that's done by itself. So sort of where somebody is on that spectrum of disease, how far that mismatch between liver and lung is, that is all weighing. And then obviously the immunologic effects if both organs are starting to get, somewhat bad at the same time, then these are all the things that we're kind of considering as we move forward.
Starting modulators early, are we seeing a decrease in the incidence or prevalence of CF-related liver disease?
So I think you're probably aware. I think the last 3 years I've given a talk at the NACFC conference on the effect of modulators on liver disease. And I think the bottom line is we still don't know exactly what they're going to do. There was an interesting paper that came out last year that was looking at organ allotment and new listings. And if you looked at cystic fibrosis patients, lung listings were down statistically by about 70% or 75%. So far less patients with CF were being listed for a lung transplant. Liver actually went up by 9%. It wasn't statistically significant, so maybe no variation. But at least in the 5-ish years of early modulator data, we're not seeing a big change. Now, when you go to the literature, some studies will say liver enzymes get better, some will say they get worse, some will say scarring scores get better or worse. The data is a little bit all over the map, and unfortunately, liver disease progresses longitudinally at a pretty slow pace. So I think we're probably another 5 years or so away from really knowing what the impact of these medications are going to be on the population level.
Just for the liver layman over here, it sounds like watch and wait, and then really the real treatment ultimately is transplant for liver at the moment.
Yeah, unfortunately, there really isn't a medication. I think Sarah was on a medicine called Actigol or ursodeoxycholic acid. It's something that is used pretty regularly. It's never really been shown to have any significant clinical impact in cystic fibrosis. The only time I really use it is if somebody's direct bilirubin is elevated. But other than that, it really doesn't have much. So it's a lot of supportive care. I will say in the era of knowing that liver enzymes go up, knowing that drugs like Trikafta and, the rest of the modulators can cause your liver enzymes to go up. We do use liver biopsy a little bit more to get an idea of to what's causing your liver enzymes to be elevated. And my personal approach, this is not based in a lot of literature, but if I get a biopsy and I see drug injury, obviously I'm going to back off the medications. If I see a lot of biliary inflammation that I think is from the underlying cystic fibrosis, I'm going to push hard not to adjust my modulator therapy just because liver enzymes are elevated, because at least theoretically there could be some benefit to these in decreasing that biliary inflammation. So again, kind of understanding the nuances of the disease and the medications that we're using to kind of tailor our approach to how we use these medications. It's not a new therapy, but it's a way we can use our existing tools to maybe help.
What is something that you wish the general public or people with CF would know about CF liver disease? As someone who doesn't know anything, what should I know that we haven't covered yet, if there is anything?
I guess something that I would like everyone to know is, I love like the online community with CF because obviously that gives us podcasts like this. But I do remember whenever I was going through so much with my liver, it was really hard to find anybody else who was, so maybe somebody was like, oh yeah, I have liver problems too. Sometimes my enzymes are high. And I'm over there in the thick of it and I'm like trying to find anyone else or anybody else to talk about it. And I didn't really hear it from my doctors until like I started to have that issue. So I was a lot like you. I really didn't know about liver disease. And even once I had it, when I was still on the pediatric side, I didn't really know what it meant. Now, luckily, my CF doctor was really good about explaining things to me, and my hospital was really good about educating me. So I loved that, but I think talking about it more like we're doing right now, that's so needed. Just other patients maybe don't feel so isolated when they're going through things like this.
Jay, how do we get more people into... Oh, go ahead. Why don't you answer that question, then I have one more. Go ahead.
So I would say the term cystic fibrosis liver disease is a historic term, and it is extremely frustrating from my standpoint and the patient standpoint because the person with mild increase in their liver enzymes didn't have the same thing Sarah had, right? Even though they're categorized as being CF liver disease. So you may have heard me kind of saying liver involvement. So we do have a new international guidelines that categorizes the spectrum of CF hepatobiliary involvement, so liver and biliary system. And the reason I bring that up is it is a huge spectrum. And as patients are living older, we are seeing more adult manifestations of liver involvement. Things like secondary sclerosing cholangitis, hepatocellular carcinoma, cholangiocarcinoma, things that we don't have a lot of expertise and stuff. So as a patient, understanding that this spectrum can be silent. You may not have outward signs and symptoms. So being vigilant about asking for those screening tools, I think is going to be really important for patients throughout the lifespan of the disease. And so that's really what I would like people to know is that the monitoring really is important in order to pick up the full spectrum.
So CF with liver involvement, hepatobiliary involvement, and if I understand correctly, you're saying, in addition to what we're seeing develop in adolescents and young adults, there may be other manifestations now that we need to recognize, as the population grows older. And sort of with that, how do we get, we need that expertise. We need people to recognize that there are these manifestations that also happen rarely. And so how do we recruit people to do this work? I mean, what do you like as far as getting around? You how are you motivating those young residents and fellows to want to, pursue a career to take care of this wonderful community?
Yeah, I think every place is a little bit different, but I think most programs like to really try to sell their research, right? And, when you have those residents and fellows, get them engaged, get your claws in them a little bit early, get them interested in something. And I don't think I have to sell them on the idea that you can actually make a difference. And the really great thing about the CF community is it's truly a community that is unique across chronic diseases. And so once you can get somebody in and start seeing the patient interaction, the academic interaction, you can start to do a little bit more of that. The Cystic Fibrosis Foundation has the Digest program that is now in its 4th year, where it trains hepatologists and gastroenterologists in GI and liver disease. I'm a part of that program and help mentor through that after being in the initial class of it, if you will. And so we continue to try to bring it together that way. But I think as the patients, the more you talk about it, the better it is. One just, kind of personal anecdotal story. One of the greatest things that ever happened to me is I won something called the Peachtree Society Award in Atlanta. I don't know if Sarah, if you know about it,
Yeah.
but I got to go to a family with a kid, a 4-year-old with cystic fibrosis. And I got to just eat a meal with them and see bedtime and see what living life with cystic fibrosis was actually like, not just being the doctor who said, go take your medicines, go take this every hour, go, seeing that life. And that's what's different. So when I have my fellows and residents, I try to get them into that patient experience, get them to a research con, get them into something like that, because I really feel like that is how we drive people into this field and continue to build on the expertise.
I love that.
First of all, that house visit, when you do a house visit, I've had the opportunity to do that. It's so revealing, and you understand the challenges, the barriers, and then also just how amazingly resilient people are. Doing a virtual visit has opened our eyes to sometimes that background in the kitchen or wherever the person might be. But I was just going to say, there is a bit of a, if we can get those providers who may not realize that they want to make a career in CF, and if we can get them to, just get involved a little bit and drink that Kool-Aid, they never want to go back. The academic, the clinical relationships, the friendships that come from this, this work is, truly amazing. So I think that we're going to pivot here and try to have a little bit of fun. So Lauren and I are going to alternate and ask questions. So this is going to be sort of a rapid question and answer situation with Andrea giving a score based on how quickly you answer and how she feels about that answer. So there's
All right.
Sarah, I wasn't prepared for this.
I was not
And
prepared
there's no
for this
wrong
either.
answers.
It's a little
You
bit of a
say that,
lightning round.
but
We
There's
like
no
to
wrong
call it-
answers, but we might judge you.
Okay.
Yeah, there's
Andrea,
no
you got the
judgment.
timer? Andrea, you got the timer?
It's called What Does This Have to Do with Anything? And the questions will start now.
Jay, best way to cut a sandwich, diagonal into triangles or midline to create 2 rectangles?
Triangles.
So you get one movie to watch for the rest of your life. What is it?
Rear Window. Alfred Hitchcock.
Ooh. Wow.
Good choice.
Jay, when Hollywood makes a medical drama about CF or transplant, what's the one mistake they always get wrong?
That one doctor does everything.
Oh, I mean, you love House, but man, there's no way you're doing it all.
Yeah.
Yeah.
Yeah, the person pulling the splinter out of your toe is not doing brain surgery. It's just not the way it works.
So, Sarah, true or false? Andrea's lungs are from 2 men over 80.
Ooh. I'm gonna say true because that's so random.
Andrea, do you want to follow through with that?
The answer is true. I was the first non-related living donor lung transplant done at Mass General in 1998. And my uncle is 86 now, and a friend of my dad would have been about 85.
Wow.
So
So
Yeah,
incredible.
That's amazing.
People.
yeah.
Yes.
Can you imagine? And also, they weren't 80. I thought, the question was a little bit like, difficult to interpret, but, they weren't 80 when they donated. But
Yeah, we were being
No,
a
they were
little
in their
sneaky.
50s.
Okay.
Yeah. Yeah.
all right,
Okay.
this one's this one probably, this one's for Jay. Pedro Pascal or Benson Boone?
Benson Boone.
Okay. Sarah, Marvel or DC?
What is Batman DC? I will say DC.
I love it. Batman is easy. All right, Jay, sweet or salty?
Sweet.
Sarah, what is the most used app on your phone?
Instagram, probably.
Me too.
All right, Jay, cats or dogs?
Dogs.
And that was the last one. I don't have
Sarah,
another.
well, Sarah, what about you? Cats or dogs?
Yeah.
Oh, I've got to have both. I have one of each. But I will say
Aw, they're listening.
that my medical pet peeve on TV is when they slam all the meds through a butterfly needle. That is probably like my huge pet peeve.
Boy, you're really paying attention.
That's definitely a lived experience.
That's amazing. I mean, because when I watch shows like The Pit or whatever, you're really kind of but you have a different lens. I know that they have people on these shows with CF or some other chronic illness that they might that consult. You should do that.
Well, my biggest pet peeve, if I may, is that the sheets are not white because they don't look good on camera. But they would never have colored sheets in a hospital because you can't bleach them.
And that stat is something that happens quickly and not based on the hospital backup. So it's going to be 2 days. And you're like, but in the shows, that's immediate.
Yeah.
So
Me,
that would be
me
my
and
other
Sarah
one.
could have a spin-off show here.
This one.
I was
This
gonna
one.
say, I
you
feel
know
like
what?
I need to have
could keep
more of an
going.
opinion here.
Yeah,
Oh, yeah.
Going.
I haven't
No,
thought
worry.
this much into those types of shows, but I feel like I need to now.
They stress me out. I can't watch them. I'm just like, stop. This isn't real. You're not
Yeah.
doing this right. So
Yeah, when my
All
wife
right.
has Grey's Anatomy on, I walk out.
Well, time is
Can't
up
do it.
for that. And congratulations on everybody who played. 67,249 points is nothing to balk at, which you both will walk out with, and you can cash out on your way out today. But seriously, thank you for being good sports. We like to, sometimes it's a serious podcast with lots of, stuff that we like to talk about, but we like to end with a little bit of fun. But we are not done with you
More
yet.
fun. More fun.
Just one
The
last
part
thing.
you've been waiting for.
One last thing. Yeah.
And I think you all remember at the beginning we played for you the lung story. I just need each of you to sing it because I would be ever so grateful. And you get extra
Gotcha.
points.
All right. Sounds good.
All right.
All right, Sarah, you going or me?
all right, I'm going for my Grammy. It's a long story. No, wait, that was not it at all, was it?
Nope,
That was
you
not.
know what,
I'm
though?
tone deaf.
No. First of all, I love that version. No, that's good. I like it. Keep it.
All righty. It's a long story.
awesome.
Like I said, I cannot sing it all.
Yeah, I can't either.
Well, it's going
I
to sort of
like
end
both
up
of
being. Does anybody remember I like to buy the world a Coke?
Oh yeah.
We're gonna, yeah. You won't even hear your voices. It's going to be like thousands of our guests
Okay.
on a
Thousands.
hilltop.
I'm trusting you on that.
Jib jab. I don't
that
know.
sounds like this is going to be in 2040.
Maybe.
Thousands
Maybe.
of guests. Good God. All right.
Well, the important thing is to have lots of ideas. It's not always to know exactly how you're going to enact them.
So you can find us on @itsalungstory on Instagram and anywhere you find your podcasts. And Sarah, what is your Instagram handle so everyone can know?
I am Sarah Joys of CF on Instagram.
Jay, what's your Instagram handle?
I am an old man. I do not have Instagram, Facebook, anything. I'm sorry.
All right. He's got TikTok.
Leave a comment if you want Jay to get an Instagram. It'll help us out a lot. Leave a review.
Said with such conviction.
Yeah.
Okay. Until next time.
Get a little older.
Live a little bolder.